Good evening, everyone. Welcome and thank you for joining AAMS Journal Club tonight. I'm Nora Agashi, President of Albanian American Medical Society. Tonight we will be talking about a very interesting topic, a problem we encounter frequently in hospital and office. Dermatology emergencies, severe cutaneous adverse reactions to drugs. We'll be reviewing few articles related to the topic. Our presenters are Dr. Aurora Shehu-Wingrove, who's also the moderator, who specializes in adult and pediatric dermatology, including skin cancer screening, prevention and treatment, acne, eczema, psoriasis, immunobolus diseases, vitiligo, surgical dermatology. She has an interest in cosmetic dermatology as well, including Botox, Dysport, and fillers. Currently working in advanced dermatology and cosmetic surgery in Beaver, Pennsylvania. And medical student, Linda Tsamai Deda. She's a fourth-year medical student at the University of Michigan Medical School, where she serves as Gold Humanism Honor Society co-advisor. She majored in biomolecular science and Spanish at the University of Michigan. Her interests include diversity and health equity, immunocompromised populations, and asylum medicine. She plans to apply for residency in dermatology and make asylum medicine part of her future career. Good luck on that, Linda. It's your turn.
Thank you. Welcome everyone to tonight's Journal Club. Thank you for the introduction, Dr. Gashi. I also want to thank Dr. Shehu for being a great mentor and helping me put together this great PowerPoint for you all. So I hope you enjoy, and if at any point there are issues with sound or viewing, just please feel free to stop me. Okay, so I'll get started. So here's a brief outline. First, we'll introduce the scars, discuss epidemiology, as well as focusing on dress for the majority of the presentation, given that that's what the articles were focusing on. We will discuss diagnostic features, clinical features, treatment, and then the two articles that were sent in the emails to you all, as well as some cases at the end. So severe cutaneous adverse reactions, or SCARs, can include a lot of different diagnoses. Here's a list of them here, including anaphylaxis, anticoagulant-induced skin necrosis, the topic that we'll be discussing most today, dress, as well as SJS and TEN. Epidemiology of scars. So skin is one of the most common targets for adverse drug reactions, and we see eruptions in approximately 1% of patients, 1 to 5% of whom are on NSAIDs, antibiotics, and anticonvulsants. 2% of all of these drug reactions are considered serious. They result in hospitalization, prolonged stay, disability, or death. And we see these in 1 out of every 1,000 hospitalized patients, which is quite common. This comprises of 2% of dermatology consultations and 5% of admissions to inpatient dermatology. So there are different ways that reactions to drugs can present in hospitalized patients. 91% present as a macular xanthum, 6% present as urticaria, and 1.5% present as vasculitis. Here are some of the different phenotypes that scars can take on. So this is the maculopapular morbilliform xanthomous drug reaction. And it's defined by widespread erythema and secondary purpuric macules on legs. And here's a picture of a patient with dress. This type of presentation is the most common ways that these present. And it is typically symmetrically distributed on trunk and upper extremities and progressively becomes more confluent. They start as flat erythematous macules and become raised plaques. Pruritus is very common and often accompanied by low fever. It can also present as an exfoliative erythroderma. Here we see diffuse coalescing erythematous plaques and papules on the trunk and arms of a patient with dress. Urticarial type is the second most common form of a drug eruption, and it's often transitory, erythematous red, as you can see in that first picture on the left, and on the picture on the right, we see a close-up of coalescing red raised plaques with secondary purpuric macules, one of which is circled there. This is in a patient with DRESS from an anticonvulsant. They can also present as vasculitis. So here we see purpuric papules and plaques, primarily on the lower extremities, as well as ulcers, nodules, hemorrhagic blisters, pustules, and you can also see digital necrosis. These lesions are often seen in crops, indicating in various stages with re-exposures. So drugs with the highest rates of drug reaction include antimicrobials like Bactrim, penicillin, cephalosporins, and fluoroquinolones, as well as NSAIDs, other sulfonamides, and aromatic anticonvulsants. This is a nice chart of the various sulfonamides that are combined with other medications. So just wanted to give a brief overview here and highlight that there is a sulfa component in glipizide as well as sumatriptan. So discussing pathogenesis or different mechanisms of scars, drug-induced reactions can have one of three mechanisms. Immunologic tends to be more unpredictable. These are also hypersensitivity reactions, whereas non-immunologic is more predictable and related to overdose or cumulative toxicity. The third type that we see is idiosyncratic with possible immunologic component, and this is the category that DRESS falls under. I'll briefly go over the different reactions. So the immunological type there, it can be IgE dependent, cytotoxic, drug-induced, immunologic complex dependent drug reaction, or delayed type cell-mediated drug eruption. And this includes the exanthamatous, fixed, and lichenoid drug eruptions, as well as SJS and TEM. The non-immunological ones can be a result of overdose, pharmacological side effects, or cumulative toxicity. We can see this with methotrexate overdose, which I'll show in the next slide, as well as prolonged exposure to amiodarone or minocycline. Here's an example of a patient with severe cutaneous reaction in the setting of methotrexate overdose. So you can see exfoliative lesions. If this gets really severe, this person might require stay in the burn unit. The non-immunological mechanism, these are delayed toxicities, for example, arsenic leading to development of SCC, alterations in metabolism, for example, bexarotene, and induction of hypertriglyceridemia and eruptive xanthomas. Or exacerbation of pre-existing dermatologic disease, such as androgens worsening acne or lithium worsening psoriasis. There are genetic factors which are shown to be linked to folks who tend to get these severe cutaneous drug eruptions, such as the HLA genes, which I have listed here. In the second column, we can see the populations that are associated with higher risk of having reactions to the drugs on the left-hand side. And I've highlighted a couple of examples here. So for example, when having like an Asian patient and you're considering starting allopurinol, carbamazepine, or dapsone, it may be worthwhile to think about possible HLA testing. Or in a Taiwanese individual starting lamotrigine, or Europeans starting allopurinol or carbamazepine. So HLA testing is available, and I'm curious to hear if we have any hem-onc folks on the line and if they do test for HLA in the setting of using allopurinol. I just included this as an example because it's controversial to screen or not to screen. In some populations where the HLA allele is more than 5% of the population, it is recommended, or in the population with CKD where they're already at higher risk of kidney injury. And below I've included the 2020 American College of Rheumatology guidelines, where they kind of lay out their recommendations. Okay, so after an overview on the various scars, we'll focus in on DRESS specifically. So DRESS is defined by various features such as eosinophilia, atypical lymphocytes, and more pronounced involvement of other systems. So DRESS is a drug reaction with eosinophilia and systemic symptoms, also called drug-induced hypersensitivity syndrome. And in the setting of anticonvulsants, this can sometimes be called anticonvulsant hypersensitivity syndrome. DRESS has a wide spectrum of severity. It can be mild or meet criteria for scar, can be life-threatening. And as we discussed, some of the common culprits are the anticonvulsants, NSAIDs, sulfonamides. And an important note about sulfonamides is that while any drug in the past 2 months can be the culprit for DRESS, sulfonamides tend to present a bit earlier, 7 to 10 days after treatment. So DRESS occurs in 1 in 1,000 to 1 in 10,000 exposures, 2 to 6 weeks after starting a medication. And facial edema is a hallmark of this rash. It's associated with fever in 80% of patients. We can also see lymphadenopathy and arthralgia, as well as many organs involved here: liver, kidney, thyroid, and lungs, to name a few. And what Dr. Shehu and I are most interested in, of course, is the skin. So I've included some pictures here of the various ways this can present on skin. Diagnostic features and things to consider when you see a drug eruption are a really good medication history so that you can attribute drug causality. And there are some tools out there that can help you determine drug causality and label them as definite, probable, or possible. Determining the latency period when the patient took the drug and when they developed the rash, as well as their course, clinical outcomes, and long-term sequelae, and resolution to their acute illness. Some things to consider in the workup are CBC, CMP, including the transaminases, and urinalysis to check for renal involvement. We check for ANA and blood cultures to rule out infection, as well as Hep A, B, and C, chlamydia, and mycoplasma. And oftentimes folks who have DRESS, they can develop reactivation of herpes virus in the setting of DRESS. In particular, HHV6 has been shown to be associated with longer duration of DRESS, as well as pulmonary involvement in 50% of patients and longer hospital stay in pediatric patients. Thyroid function should also be checked, as DRESS can involve the thyroid, and testing can be repeated 2 to 3 months after the drug insult. For the reactivation of the herpes virus, the explanation is controversial, but it could be due to a result of an immunodeficient state, because during the acute stage of drug eruptions, T regulatory cells are expanded and B cells and immunoglobulins are decreased, which makes folks more susceptible for reactivation. If herpes virus reactivates, this can be a tricky situation, because the immunosuppressive treatments needed to treat DRESS may need to be decreased in the setting of a reactivated infection. So here's just a quick reminder of the various herpes viruses that can be reactivated during DRESS. This is a scoring system used to, it's a validated tool that is used in daily practice to differentiate between possible, probable, and definite cases of DRESS. We can see there, we can classify DIHS or DRESS as presence of all 7 criteria, or atypical DIHS, also known as DRESS, if there's only the first 5 criteria. Some clinicians will use this tool differently to distinguish between DRESS minor and DRESS major, which I'll talk about later. And the scoring for that is 1 to 3 or 4 to 9. But looking through the criteria, something I want to point out is that this requires the clinician to know the involvement of internal organs. as well as the resolution of the rash. So this is not a good tool for screening patients who may develop DRESS, but it is a tool for diagnosing DRESS after it is already on board. So different treatments for DRESS include early withdrawal of the drug, supportive therapy, and systemic and topical steroids. This can be required for weeks to months. And then systemic steroids, typical dosing 0.5 to 2 milligrams per kg per day of prednisone are particularly important in patients with renal or pulmonary involvement, and it has unproven benefit for those with hepatotoxicity. Follow-up labs 3 months after withdrawal of medication are important, as well as I mentioned earlier, CBC, LFTs, BUN, LFTs, and urine sediment. It's important to counsel family members thinking about the HLA alleles which are associated with some of these reactions. There's a fourfold higher increase in first-degree relatives. So now we'll jump into the articles. The first one I'll go over is looking at clinical, biochemical, and serologic predictors of drug reaction with eosinophilia and systemic syndrome. So I'll go right into the study objectives. So the chart that I showed earlier, the Regiscar, can help us validate a diagnosis of DRESS, but there is no easy tool to identify DRESS at presentation. And the goal of this study was to identify clinical and serologic markers to predict DRESS at the time of presentation, comparing this with other maculopapular eruptions. The methods that they used, this was a prospective observational study in India. They looked at 50 patients total. The inclusion criteria were any patient with a maculopapular rash, 25 with, split into 25 with DRESS and 25 controls. They used that Regiscar scoring system to identify the DRESS folks, and they used any patient with fulfilling the criteria for possible, probable, or definite DRESS. Here's a diagram of what the methods in coming up with the case and the control look like. Really quickly, this is kind of a busy slide, but for all cases and controls, the causative drug was identified by an algorithm of drug causality for epidermal necrolysis score. So this is not a tool necessarily for DRESS, but it was used to identify the causality of the rash for these patients. Baseline clinical, biochemical, and serologic markers such as high sensitivity CRP, ESR, and thymus inactivation regulated chemokine or TARC levels were reported. TARC is a marker that I was previously unfamiliar with before I read this paper, so I just wanted to go over it. TARC is a marker which recruits Th2 polarized T lymphocytes into local inflammation sites, leading to Th2 type immune reaction. So the most common primary illnesses seen in these two groups, looking at DRESS, the most common primary illnesses were IBD or inflammatory bowel disease, osteoarthritis, epilepsy, and tuberculosis. And the controls, they had more acute presentations such as tropical fever, again, osteoarthritis, meningitis, headache, or transient ischemic attack. This is what the timing looked like between the patients with true DRESS and the controls with another type of maculopapular eruption. So looking at the time between starting the drug and symptom onset, we can see that DRESS had a longer latency period of an average of 19.2 days compared to the controls about 4 days. Then looking at the timing between the onset of symptoms and presenting to the hospital or to the clinician, DRESS patients also tended to present later at an average of 6 days, whereas other patients with maculopapular rashes presented earlier at about 2.5 days. When comparing symptom onset to how long did it take to stop the culprit drug, it also took longer to stop the drug in patients with DRESS, about 4 days compared to controls, which was 1.5. The appearance of the rashes also differed in the two groups, whereas, so both had a macular morphology. That was one of the inclusion criteria for both groups. But in DRESS, we saw there's a little bit more variety, such as 2 patients who presented with vesicles, 4 which had a more eczematous presentation, and 13 which had a targetoid lesions. Facial swelling was present in 88% of cases, or the DRESS patients, whereas only in 4% of controls. And I actually show this on the next slide here. So as you can see, facial swelling was there's a huge difference here between DRESS and controls. And as I mentioned earlier, it's an important clinical indication. Lymphadenopathy was seen in 76% of DRESS patients, and it was seen in none of the controls. So looking at the DRESS group, what was the systemic involvement? 80% had liver involvement, 32% had renal involvement, 12% had pulmonary involvement, and 24% had a combination of various systems involved. There are certain predictors, so increased age, increased total body surface area, the mean eosinophil count, and CRP, as well as ESR, were correlated with renal involvement, whereas increased pulse rate, TBSA, or total body surface area, total lymphocyte count, eosinophil count, and CRP and ESR were correlated with the multi-system involvement of listed here. So the TARC level, which I mentioned earlier, again, this is the serum thymus activation regulated chemokine. This was found to be 88% sensitive and 100% specific in predicting patients who later developed DRESS. And it showed that there's excellent diagnostic performance in predicting. The cutoff value that they determined was about 600. However, the downside to using TARC was that it did not correlate with severity or organ involvement. So it's helpful in determining DRESS or not DRESS, but not necessarily how sick is your patient going to be. Other parameters that were able to individually differentiate between DRESS and other maculopapular eruptions included TBSA, CRP, eosinophils, absolute eosinophil count, as well as AST. And then interestingly, among patients with DRESS, even though TARC was a helpful marker, it did not show correlation with these other serologic markers. So in other words, when these serologic markers were high, TARC was not necessarily always high or correlated in that sense. So the results showed effectiveness of TARC, TBSA, CRP, eosinophils, and absolute eosinophils, as well as AST. They were statistically similar to effectiveness of Registrar DRESS validation score, which is the gold standard. The results showed that a TBSA of greater than 35, CRP greater than 5, and eosinophils of more than 6% had greater odds of being diagnosed with DRESS. And the researchers came up with this algorithm here so that if you have these markers for your patient, you can plug and chug them here and see what the odds of them developing DRESS are. The cutoff that they determined for this equation was 6.8, and it showed to have very good sensitivity and specificity, as well as diagnostic accuracy. So the number one take-home point for this study, it is difficult to differentiate DRESS from other maculopapular drug eruptions at initial presentation. And this challenge can delay treatment and result in unnecessary hospitalization for monitoring folks with the mild maculopapular eruptions. So it's important to suspect DRESS when there's a longer incubation period, facial swelling involved, infiltrated rash, and internal organ involvement, looking at hematologic and lab values. And the baseline serum thymus and activation regulated chemokine, or TARC, can differentiate DRESS from other maculopapular rashes. However, it does not necessarily correlate with severity or organ involvement. There are other studies out there that actually do show that TARC is correlated with internal organ involvement, but this study in particular did not show that correlation. And TBSA, CRP, and eosinophil percentage can be used for early identification of DRESS. And these parameters are also helpful because they correlate with the severity of disease. Again, here's that equation that they came up with to screen patients with suspected DRESS at early stages of presentation. After using something like this as a screening tool, diagnosis can be further confirmed by the registrar system that I showed you earlier. Okay, so on to the next paper. This one is looking at discriminating minor and major forms of drug reactions or DRESS. And they found that facial edema aligns with the severe phenotype. So the study objective here, are there cutaneous or dermatopathologic features that discriminate between mild forms of DRESS or DRESS minor with more severe forms or DRESS major? Methodology, this was done between September 2012 and 2019. There's 45 hospitalized patients from a single center with a diagnosis of DRESS who had exanthem as well as systemic features, and they were prospectively recruited over a 7-year period. They looked at clinical as well as dermatopathologic features to see if they can distinguish between DRESS minor and DRESS major. So they collected information on demographics, medication history, clinical findings, disease course, clinical outcomes, and they also used this registrar scoring system, but they used a score of 1 to 3 to label folks as DRESS minor and 4 to 9 to label folks as DRESS major. Here's a table showing the group with DRESS minor and the most common drugs and underlying disorders seen in this population. So we can see epilepsy and various anticonvulsants that we discussed earlier. This is the DRESS major group. And we can see the drugs and disorders that came up in this group. So the researchers assessed cutaneous findings on days 0, 2, and 4. They took photos on days 0 through 4, and each patient was labeled to have one of these eruption types, either macular dermatosis, urticarial, or exfoliative erythroderma. They looked at systemic features, which we discussed earlier, and also reactivation of any of these herpes viridae. They also looked at dermatopathologic features, which we have not discussed yet. There was a skin biopsy taken within 74 hours of presentation from all 45 patients, and the dermatopathologist who was unaware of presence or absence of systemic features identified 7 morphologic variables, and I'll discuss later which ones were correlated with or were more prevalent in folks with DRESS major. So again, they looked at systemic features, cutaneous, dermatopathologic, and general outcomes. Looking at the systemic features, folks with major tended to have higher eosinophilia, higher AST, fever, and a reaction lasting longer than 15 days, as well as lymphadenopathy. And these were all statistically significant differences between DRESS minor and major. The cutaneous features, we discussed earlier that facial edema is an important marker of DRESS in general, and it's also an important marker of DRESS major specifically. Here's an example of cutaneous features in dress, major and minor. Facial edema is a prominent sign of dress and often accompanies the inflammatory dermatosis. And then here we have the dermatopathologic features. I'm sure most of you just want to know what the end result of the biopsy is, but I've put here kind of what the various words that the dermatopathologists use. So when they found that in dress major, there was more likely to have epidermal necrotic keratinocytes and basal cell squamatization. And these are both indicative of tissue response to keratinocyte damage. And then red blood cell extravasation is indicative of endothelial cell damage. Here's a histopathologic photo, so we can see the epidermic necrotic keratinocytes here, basal cell squamatization in this layer here, as well as interface inflammation and red blood cell extravasation. So the study looked at patient outcomes. In the dress minor group, 6 received systemic corticosteroids during the acute phase. None had a prolonged course or needed additional systemic immunosuppression, and they did not see prolonged internal organ involvement, autoimmune thyroid disease, or diabetes in this group. In the dress major group, they all received systemic corticosteroids during the acute phase, and they all had a prolonged course of corticosteroids, or not all, sorry, 9 out of 26 did, and 4 needed oral cyclosporin for long-term treatment. Looking at liver complications in this group, there was 1 patient that had acute hepatic failure and another patient who needed a liver transplant during the acute phase, as well as 9 patients with prolonged liver inflammation, and 2 of those 9 also had renal impairment. 1 patient developed autoimmune thyroid disease in the post-acute period, and 1 also developed diabetes as a late complication. Other findings, there was a shorter latency period in dress minor, and there was more exfoliative erythroderma seen in the dress major group, but this was not a statistically significant difference. So to recap, the take-home points from this study, there are important differences in patient outcomes when comparing dress minor and dress major. Patients with dress major can suffer a potentially life-threatening course, requiring more intensive care and immunosuppressive treatment. Awareness of the systemic, cutaneous, and dermatopathologic features associated with dress major can help you increase your diagnostic sophistication, offer your patient a graded prognosis, and identify patients benefiting from active intervention. Next take-home point is that facial edema is a key cutaneous discriminator between dress major and minor. And to note that sometimes the presence of facial edema can lead clinicians to consider angioedema in their differential diagnosis. Fifth take-home point are the 5 dermatopathologic features that aligned with dress major and were underrepresented in dress minor. So when you receive that pathology report from your biopsy, you can see if your dermatopathologist colleague commented on any of these 5 features here. So is this a good time to pause for questions before going to the cases, Dr. Shehu? What do you think?
Yeah, that would be wonderful. Anyone has any questions so far? I know it was quite extensive, so Linda did a wonderful job going over, first of all, what the causes are for all the drug reactions, right? The big picture first, and then focusing on dress. So dress, it's almost like a spectrum. And so, right, you first look for something, like you said, micropapillary eruption. That's why we chose that paper, because it shows that from simplest micropapillary eruption, right, you see like red, very flat, or sometimes raised plaques. All of a sudden you go into much more involved into dress. So I think she did a wonderful job summarizing that paper. showing, okay, you have the two dress and then the micropapillary. What the authors were trying to do is say, hey, you know what, if we have something that we can do like an ELISA, a test, right, that'll be wonderful. Unfortunately, though, you can do that, but then, right, like she said, though, very nicely, it doesn't correlate necessarily with involvement of how much systemically that's the case. And she did a wonderful job saying, oh, wait, well, maybe, we do a biopsy. What is on the biopsy versus, something is in the early stages of the dress on the minor versus the major. And so then the involvement and also the treatments are quite different, topical versus systemic, right? And I think it's a wonderful job. And at the end, then I think working on the case will tell you a little bit more about the different disease that we think about, more differential when we think about just simple drug eruption. And so, any questions so far?
Yes, Linda, you did great job, great presentation, and I'm definitely learning stuff today about TARC. I didn't know it exists. So this question is more for you, Aurora. I just need to know about the timeline from cutaneous eruption to systemic involvement. Something that we encounter in hospital, and when is the good time, when is safe for patient to go home?
Yeah, so it's always to do with the end results, right, with systemic involvement. So for example, if their liver, lungs, and kidneys, if they are all stable, then the patient are okay to go at home. So the dress is not about how the patient's skin looks. Once you put them on oral steroids or cyclosporin, I even have actually a patient where I put him on Humira. The problem with this though is that the skin looks great, but the end organ though are the ones that we're most concerned about. So if they are stable in terms of the organ wise, they're more than okay to be discharged. And of course, follow closely with the PCP afterwards or with a specialist, whoever follows them. So the key is always is the systemic involvement, not really truly the skin.
Right.
The skin will resolve very quickly for them. And that's why, unfortunately, they stay long on the hospital. It's because of the complications from the systemic more than dermatological.
Okay. And then there's I think the slides show that the biopsy should be taken within 74 hours.
That's the best way. So, right, I mean, the longer you wait, the problem is that if there is one, so dress changes, right? Dress can be multiple, because the differentials can be so wide. It can be micropapillary, right? It can be vesicles, it can be exfoliative. And so sometimes then it can gear towards other differentials where it might not necessarily be, be correct. And so the earlier you have the biopsy, the sooner you'll see a lot of the reaction. That's one reason why I want the earlier, and you diagnose it earlier. That's why we say 72 hours. But today, actually, I just came from a consult. The patient was seen last week in one of our houses, Presby, and he was an HD patient, was put on carbamazine when he left the house, and he came back then 1 week later, and a 59-year-old African-American male, and he developed now a lot of the blistering, and he first started almost like micropapillary. You could see in his extremities, the trunk. And then, however, though, he had a lot of spatial edema, like typical cases that Linda was mentioning. And so I did do a biopsy on him, and I'm waiting for it, but I'm pretty sure that I will see a lot of necrotic keratinocytes there. And the thing about the necrotic keratinocytes, you also see them, bravo, very nice. You also see them, unfortunately, also in the TN or SJS. And so that's why the earlier you have the biopsy, so the earlier we are called, the better it is, because then we don't send the patient to a tertiary center to be treated for SJS or TN unnecessarily. And so that's why we say within 72 hours when it appears.
Okay. If you have a dermatology on board.
Yes.
Great, thank you.
This was very helpful. Thanks, Linda and Dr. Shehu. We get a lot of transfers from smaller community hospitals.
Mhm.
Our hospital is the closest to serving all of northern Michigan and the Upper Peninsula. So we get a lot of transfers for like necrotizing soft tissue infections and all that stuff. And then ends up not being anything at all. So it's really nice to kind of know these different rashes. And I mean, we get consulted all the time to biopsy these rashes. So it's nice to have some background of what kind of things to look for.
Yeah, I think it's a tedious job to look for the medication that can cause this. And so, because if you find a medication, you have to withdraw and stop it. And so that's why Linda was saying that you have to have the tools to kind of systematically see when they were exposed. And don't forget too, even over-the-counter medication can do that too. And so I think the time when they receive the medication, I think is important, but also making sure that you have a complete list of medication, including over the counter, so they can also cause this too. So having that at hand for someone who is not well or who doesn't know what's going on is sometimes difficult to do. So for us, many times we have to call the pharmacy the patient goes to, the pharmacist, to see what medication the patients had. So having a thorough list is half the job.
Edna made an excellent point in the chat that we can always consult the pharmacist if we have access to them.
Oh, okay. All right, just so I know that.
Okay, so I can move on to the cases, and we can also have time for more questions at the end. It looks like we're a little bit ahead of schedule. Let me get over to the cases. So this first case, we have a 38-year-old man who was started on carbamazepine 6 weeks ago for new onset seizure disorder. He developed an exanthem pictured here, as well as high fevers, facial edema, and lymphadenopathy. Lab evaluation demonstrated leukocytosis and elevated alanine aminotransferase. And the patient's symptoms initially worsened after discontinuation of carbamazepine. So could I have one brave person give us a guess which of the following is the most likely diagnosis here? So I'll go. Oh, go ahead.
See.
Excellent. So I'll go over some of the choices here. Morbilliform drug eruptions occur more frequently without systemic symptoms, whereas this patient did have systemic symptoms, and they can be induced by systemic antibiotics, although almost any medication can be implicated in option A, the morbilliform drug reaction. And these typically come about 1 to 2 weeks after drug initiation, whereas this man developed the symptoms 6 weeks after. For option B, lupus, this tends to present as a symmetric annular or polycyclic papulosquamous eruption, predominantly in sun-exposed areas. And then drug-induced lupus cannot be reliably distinguished from idiopathic forms, so there are no consistent differences in clinical, histological, immunological, or laboratory features. And then briefly touching on SJS and TEN, these tend to present abruptly with tender, painful erythema, which usually begins on the trunk and then spreads to involve other areas. Patients initially present with a morbilliform eruption or flaccid bulla, and then the rash quickly progresses to widespread erythema and sloughing. There's also mucosal involvement in SJS and TEN, which is not seen in DRESS. And then here are some nice pictures of SJS and TEN. So this first one is highlighting the mucosal involvement as well as the picture below. And then just to recap, how do we differentiate between SJS and TEN? They are on the same spectrum, but we differentiate them based on total body surface area involved. So when it's less than 10, we call it SJS. Greater than 30% is TEN, and then there's kind of like a spectrum in between as well. Okay, case number 2, we have a 74-year-old man with panhypopituitarism secondary to craniopharyngioma resection, vision lost of the left eye, neurogenic bladder, and obstructive sleep apnea. He presented to the ED with a new onset rash beginning 3 days after receiving the Janssen vaccine. To briefly recap his history, he has allergies to sulfa drugs as well as amoxicillin clavulanic acid. He's had no previous vaccination reactions or recent illness, no medication changes. And as background, he takes prednisone 5 milligrams daily for adrenal insufficiency, which was recently increased to 20 milligrams daily for what was thought to be a stasis dermatitis flare. So here are some pictures of this man's physical exam. So we see a generalized distribution covering 50% or more of his body surface area. We see erythematous plaques studded with numerous small non-follicular pustules. The rash spared his face, genitals, and mucosa, and he had significant acral swelling in the absence of any palpable lymphadenopathy. Within 13 days of him presenting with symptoms, he showed an absolute neutrophilia, elevated eosinophil count, which tripled within 24 hours, as well as a creatinine, which elevated transiently and returned to normal. And of note, his AST and ALT was within normal limits. Here's what his biopsy of his right shoulder looked like. We can see epidermal spongiosis with focal, occasional subcorneal neutrophilic pustules and dermal neutrophilic inflammation, with eosinophils consistent with a spongiotic and pustular drug eruption. And then a DIF study or direct immunofluorescence study from the same site was negative. So going over a differential diagnosis that was considered in this patient, AGEP, which I'll discuss in a little bit, DRESS, SJS, and TEN. So AGEP is the one that we haven't heard about yet, so I'll take this opportunity to summarize that diagnosis. So AGEP, we see numerous small sterile pustules arising in large edematous erythema, as is seen in this upper picture here. These patients have high fevers. 90% are drug-induced, notably from macrolides, hydrochloroquinones, and terbinafine. And the rash occurs 1 to 2 days after drug exposure. So the timeline, it looks pretty different compared to DRESS. This rash starts on the face and intrigines and then spreads to extremities and the trunk. And the treatment for this is to stop the drug, and similar to DRESS, treating with topical corticosteroids. And because these folks tend to have high fevers, antipyretics are also important. So I'll go back to differential diagnosis. So this was not a straightforward case, which is why a case report was written on it, I presume, and showed some overlap. So this was ultimately a DRESS and AGEP overlap based on clinical findings and the clinical picture of the patient. So these are after pictures when the patient was treated with 20 milligrams of prednisone daily, as well as topical steroids. This was 120 days after treatment, and his liver enzymes and creatinine continue to stay stable and within normal limits, and his eosinophil count also came back to normal range. Okay, so last points here, when considering these scars or severe cutaneous adverse reactions, any drug can cause a cutaneous reaction, and any cutaneous eruption may be drug-induced. So it's important when seeing a patient that you suspect has a scar to discontinue all drugs that are non-essential, and then to determine the drug that is most likely involved. To help determine that, we can look at the type of eruption as well as histopathologic findings, the timing of events, a literature search, withdrawal as soon as possible. For more mild eruptions, we can get away with topical steroids and antihistamines. But for more severe or life-threatening cases like DRESS or TEN, it's important to have systemic therapy on board, like IVIG and corticosteroids. So I'll pause again for questions. This is the true end of the presentation. So thank you all for your attention and participation. And I'll open the floor to questions for Dr. Shehu and I.
Hi, good evening, everyone. This is Ariane. That was a very excellent presentation, very detailed. Can you guys hear me? Just want to make sure. Quick question on someone who's a hospitalized patient in polypharmacy, and you kind of touched on it on your last slide. How do you know which drug is the culprit? Number one. And the question two is, say someone has vasculitis with multiple skin lesions. How do you know which skin lesion to go after for biopsy? Or you just pick one on random?
I will let Dr. Shehu take this one. You're muted, Dr. Shehu.
Oh yeah, sorry. So you mean if you have the vasculitis, how do you know which of the lesions to go get?
Does it matter which lesion you pick out? Or
yeah. Yeah. So when it goes to vasculitis, right, it's a very, that's one thing actually that I always get consulted for, is to rule out vasculitis. And vasculitis is, it's not an easy thing to diagnose, unfortunately. You know what it is, like the pathology, but the key is not to see what it is, more what is the reason for vasculitis. So it can be autoimmune, it can be medications, it can be infection. And so the vasculitis is such a large topic, unfortunately, though. But however, though, the medications is like the number one, I think, not number one, but the most common cause of vasculitis is medication. After that, though, it's idiopathic, that we don't know why sometimes vasculitis occurs. But in this case, though, if it is the vasculitis, the biopsy is taken mostly from like the area where vasculitis is present, but also also adjacent to it too, because we have to do, the pathology for just looking at the slide as it is. So it's like H&E, but also look at the DIF too, to rule out any autoimmune disorders too. And so DIF will be immunofluorescent to look at. So usually if we suspect vasculitis, we only take 2 biopsies. We always take 2 biopsies, one for the pathology, look at it, and then the other one for fluorescent studies to be done in the biopsy, which is adjacent to the one that you take actually. And so that's how we usually do the biopsies for the vasculitis. But again, though, you have to also know if it's medication. And again, many times it's just idiopathic, but you have to rule out also infection, you have to rule out also autoimmune too. And so vasculitis is a very large topic when it comes to to dermatology. And we can do another journal club for vasculitis. Actually, I love vasculitis, so it's one of my specialties. So I would love to do one. And I think there's a resident here too, I think. I just saw, I didn't realize that through all the messages. So.
That was great, thank you.
I think for Fiona.
I was gonna make a comment too. Let me just, I'll turn my video on. Hi guys, I'm Flutie. I'm one of the derm residents.
Great. Hi, Fiona.
Hi, so I was gonna say, hi, Dr. Gashi, how are you? It's good to see you through Zoom. So I was actually going to answer the question in regards to how do you pick a drug? And, as a PGY4, I'm towards the end of my residency, but it's the bane of our existence to like pick the drug, right? So I think there's a couple of things that you could do to narrow it down. The first thing would be the timeline, right? So I think Linda did a great job at pointing out kind of the time frame. So when you're looking at AJEP is 1 to 4 days. So if someone comes in with a pustular eruption and they took an antibiotic 3 weeks ago, then it's not AJEP, right? Then the next one, SJS or EM, which is a spectrum, that's usually from 1 week to 2 weeks. And then for DRESS, you're looking at 2 weeks to 6 weeks. So depending on what our clinical suspicion is, so if I'm suspecting DRESS, I'll go back 6 weeks to the presentation of the rash to determine, which drug it might have been. So looking at the time frame will definitely help you out. The other thing would be, you think of common things being common. So allopurinol, dapsone are common, and then always go for the antibiotics. If you don't know what you're going for, it's most likely one of the most recent antibiotics. So it's difficult, but when we get a consult, at least at our hospital, we make a drug chart, kind of showing when the rash started and then going back X number of days, depending on what our clinical suspicion is, and then narrowing it down to the most common drugs that could cause this, like Linda is showing here, which is very helpful. So you think of the most common things. So anticonvulsants, antibiotics, and then a few kind of special ones here and there. But that's kind of how you try to narrow it down.
Thank you. That is so helpful. Any other questions?
Mariela said to the group, and thank you, Mariela, for that, since I'm a PCP. It's important to check the thyroid function test 3 months after episode, says they can get delayed hypothyroidism. So yeah, that's helpful. I didn't know that.
Yeah, they actually can get myocarditis, pancreatitis. Thyroid is the most common. So that's the one where we check a TSH and free T4 commonly. But usually if you have a DRESS patient and they're complaining of symptoms of any itis, just kind of be on the lookout. So thyroiditis is the most common, but we've seen also myocarditis and a few other ones as well.
Thank you. Okay, any questions? Any other questions? Anyone? We have 2 dermatology residents here, Mariela and Fludiona. Thank you for joining us.
Great job, Linda. It was excellent. I'm sure you'll be ready for your interviews, right?
Thank you. And thank you to Dr. Shehu for being so helpful in helping me put this together, for teaching me along the way, and helping prepare me to present this to you all.
Thank you, everyone. Nice to virtually meet you very briefly.
Thank you.
And Mariela is my New York co-resident, even though we are at neighboring institutions. She's at Cornell, I'm at Columbia, but we know each other well. So it's nice to have her here.
Well, Mariela, it's time to join AAMS, and next time maybe we'll have a presentation from you and you, Fludiona.
Sure. Thank you so much. It was very nice to hear about this event, and great job, everyone.
Great presentation. Thank you, everyone, and we can conclude this journal club. And please, if you have any suggestions, any new ideas for journal club, you can contact us and we can organize it and help you with presenting and everything.
Great job, Linda. Thank you, everyone.
Okay, bye-bye.